Hello guys, Assalamu alaikum. I'm Immad Ashraf. I'm a second year medical student, and today we're gonna have the session about the thyroid gland, including its anatomy, some of its physiology, and the histology. I was supposed to give this last week, but I couldn't because of some issues. But inshallah, it shouldn't be too hard. It was one of my favorite topics in EndoRepro, and I really liked EndoRepro as a whole. So let's get into it. Bismillah. You can contact me on my number or email if you have any doubts after the session. So the thyroid gland is around 30 grams and it's larger in women. It's surrounded by two layers, a connective tissue, which is called the capsule, and then the pretracheal fascia, which is known as the false capsule. And both of these are very important. We'll get into them in a minute. And then it has two lobes usually, but there may be a third lobe in some people, and we'll again discuss that in a bit. So the pretracheal fascia, also known as the false capsule, connects the thyroid gland to the tracheal ring, and hence the thyroid gland moves up and down with the larynx during swallowing. So basically, it connects the thyroid gland to the trachea. And it's useful clinically because if there is a swelling in the neck, we can ask the patient to take a sip of water. And if the swelling moves, then it's a thyroid swelling. Otherwise, it's not. So, as you know, if you take a sip of water, you're going to be swallowing, and this is going to move the trachea. And then if this swelling moves, then that means it's connected to the trachea, because if it's moving with the trachea, it's connected to it. So if it moves, then it's something to do with the thyroid. And if it doesn't, then the swelling is not related to the thyroid and it's something else. So the isthmus is what connects the two lobes of the thyroid gland. And the location is anterior to the second and third tracheal cartilage. So the trachea, uh, it's anterior to the second and third cartilage. And sometimes, as I said earlier, there may be a third lobe, which is called the pyramidal lobe. And this ascends from the isthmus to the hyoid bone. And I'll show you a diagram in a minute, but just remember that for now. There can be a third lobe called the isthmus, called the pyramidal lobe. And the two right and left lobes are connected by the isthmus. And it's clinically relevant because in some cases, we have a procedure called the cricothyroidectomy, which may be required if the endotracheal tube isn't available or cannot be placed. So the endotracheal tube is something to assist with ventilation and breathing in sick people. But if you can't use it, then you do a cricothyroidectomy. And in some people, the pyramidal lobe covers the cricothyroid, which is a ligament, like it's a fascia or ligament. So during the procedure, a lot of bleeding may occur if you incise or if you cut the pyramidal lobe. But this doesn't necessarily mean that a blood vessel has been hit. It could just mean that that person has a pyramidal lobe, and in while doing the incision, you might have hit the pyramidal lobe, which causes all the bleeding. Okay, so this is the diagram that I want to show you, and hopefully it'll be clear after this. So please follow the laser pointer. So this is the left lobe, right? This is the right lobe because it's flipped. And then this is the isthmus, which connects both of them. And then in some people, we may have this pyramidal lobe, which extends above. You see here? So in the diagram, it says the cricothyroid ligament is this, but this is a mistake. It isn't actually this. This yellow line, which leads to this ligament over here, is the cricothyroid because it's between the thyroid cartilage and the cricoid cartilage. This is why it's called the cricothyroid. So please ignore the diagram. This is incorrect, and it was incorrect last year as well. So this is the cricothyroid. And then, as you can see, the isthmus is at the level of the second and third cartilage. So this is the fourth, fifth, and sixth, and above this we have the third and second. So that's where it is. The borders are the diagonal side of the thyroid cartilage is the upper border. So the diagonal sides, which is this. The lower border is the sixth thyroid cartilage. So the sixth thyroid cartilage. The lateral border are the carotid arteries, and we'll delve into this in a minute. And then the isthmus is at the level of the second and third thyroid cartilage, which we already said. Okay, so anteriorly, its relations are as follows. So at the medial anterior surface, we have the relation to the esophagus and trachea, obviously. because we know that esophagus and trachea are like at the midline, and that's why it's related to them. And there's a diagram after this, which will hopefully make it easier for you to see that. Laterally, we have the sternohyoid and sternothyroid muscles, and they're deep to them. So they're kind of they're lateral and they're also kind of posterior. So you could say they're posterior lateral. And then completely posterior, we have the carotid sheath, which is the CCA, which is the common carotid artery, and the IJV, which is the internal jugular vein. Uh, this is what's within the carotid sheath, and it's clinically relevant because in the cases of goiter, which is the swelling of the thyroid gland, the trachea and esophagus may be compressed, causing difficulty swallowing and breathing because it's compressing them because of the swelling. And I have a diagram. Hopefully, you'll see it in a minute, like the next slide. As I said, the IJV and the CCA, internal jugular vein and common carotid, lie posterior lateral to the thyroid in the sheath, the carotid sheath. And as I said earlier, the inferior border is the sixth thyroid cartilage, so it extends to the sixth thyroid cartilage, and it attaches to the arc of the cricoid cartilage, an oblique line of the thyroid cartilage, and we'll see that in a second. And obviously, this is the reason for it moving with every swallow because it's connected to the thyroid cartilage. So every time the thyroid moves, it's also going to move with it. Okay, so this is the sternothyroid muscle, and this is the sternohyoid muscle. I think you guys may have done this earlier in GIT. But anyways, these muscles are posterior lateral to the thyroid. And then we also have the esophagus that's anterior. I don't think I put a picture, but I but just remember that the esophagus is anterior to the thyroid. And then laterally we have the muscles, and posteriorly we have the carotid sheath, which is basically which contains a common carotid and then the internal jugular vein. And then also clinically relevant because if you have goiter, it could cause compression of the trachea and esophagus. Now we move on to blood supply, which is very important, by the way. There's a lot of questions relating to the blood supply and the nerves, so this is a very important section. So the main supply is from the superior and inferior thyroid arteries, which lie between the capsule and the false capsule. So they lie in between the connective tissue and the pretracheal fascia. They're in between it. And all of the arteries anastomose with each other. The first one, the superior thyroid artery, is the first branch of the external carotid artery, the ECA. And the diagram will make it more clear. It runs to the upper pole of the thyroid, so it supplies the upper part, which is evident by the name. Then it pierces the false capsule and divides into many smaller arteries. It then anastomoses with STA branches from the other side. So the right superior thyroid and the left superior thyroid will give branches that anastomose with each other. Then we have the inferior thyroid artery, which is the branch of the thyrocervical trunk, which runs superior-medially posterior to the carotid sheath. So what does that mean? It runs medially and then it goes up superior, and all of this is happening posterior to the thyroid gland. And I'll show you the diagram in a second, and that'll make it more clear. It basically it runs in a groove between the trachea and the esophagus. So there's a groove between the trachea and esophagus, and that's where it runs. It supplies the inferior pole, obviously evident by the name, and it has an ascending branch that anastomoses with the posterior thyroid artery, which is another artery that's not very important, but this is an important anastomosis. So here we have, first of all, let's start with the superior thyroid artery. Where is it? Okay, this is the superior thyroid artery. Okay, it's coming from the external carotid. And as you can see, it's going to the upper pole and it pierces and gives so many branches, which anastomose with the other branches coming from the from the thyroid artery on the other side. Then we have the inferior thyroid artery, which is this here. And what do they mean by superior medially posterior? You can see it's going medially. It's also ascending, so it's superior, and then it's posterior to the thyroid gland. So that's why superior medially posterior. And it's coming from the thyrocervical trunk. It's labeled here. It's coming from the thyrocervical trunk, right? So those are the two arteries you need to know right now, and we'll come back to this diagram for the veins. But yeah, and then we have the posterior thyroid artery, which also anastomoses with the ascending branch of this inferior thyroid. Okay, now the thyroidectomy is basically a procedure that involves removal of the thyroid gland, or at least a part of the thyroid gland. So obviously arteries need to be clamped for the thyroidectomy. There are four parathyroid glands, which are fused to the posterior surface of the thyroid, so they're connected to the thyroid. And hence, we don't usually perform a total thyroidectomy, which is complete removal. We usually perform subtotal thyroidectomy, which is partial removal. We spray the posterior surface of the thyroid. If we remove the whole thyroid, the parathyroid may be damaged, leading to decreased secretion of PTH, which is parathyroid hormone. So the PTH is secreted by the parathyroid gland, and we don't want to damage it because it will lead to decreased secretion of PTH. And what would this cause? It will cause decreased calcium levels in blood because the parathyroid hormone is responsible for calcium regulation and metabolism. And it could cause tetany, which is basically spastic paralysis of the limbs. So that's why we don't usually cut the whole thyroid off, because the parathyroid is connected to it and we don't want to damage it. So we usually spare the posterior surface because that's where the parathyroid glands are attached to the thyroid into the false capsule. Okay, now we have the vessel relations and the extra artery. So other than the superior, inferior, and posterior thyroid, we have another artery called the thyroidema artery, which is only present in 10% of people. It arises directly from the aorta or the brachiocephalic trunk or the internal carotid. So because it's so rare and most people don't have it, it has like many different anatomical origins. It ascends anterior to the trachea to supply the isthmus. And it's clinically relevant because during tracheostomy, which is basically piercing of the trachea, which you do when like someone has choked and they can't breathe, you must like, when they like in case they can't get a tube in and like someone's choking and then they do a tracheostomy. You must have seen it in movies and stuff. So during the tracheostomy, this artery may be damaged and this causes bleeding. So basically, it runs somewhere over here, okay, and it comes directly from the aorta. So this is the arch of the aorta, and it just ascends, and then it's somewhere over here. So in case of a thyrostomy, and then it would basically be cut, and this could cause bleeding. But like it's just like it's unfortunate, but like it doesn't mean that you have anything serious because like it's just present in 10% of people, so it's fine. Then we have the nerves, and there's two of them, and these are some of the most important things in this lecture because you're guaranteed to get a question about the nerves and arteries relations. So the first one is the external laryngeal nerve. It lies very close to the superior thyroid artery at its origin. So when the STA originates from the external carotid, that's where it is in relation to the external laryngeal nerve. So sometimes while we're ligating this STA during a thyroidectomy, the nerve may accidentally be damaged. This nerve supplies a muscle called the cricothyroid muscle, which you guys must have done earlier, and is responsible for frequency. So the damage of this muscle, because of the loss of innervation, causes bowing of vocal cords, and the person then has a lower frequency, which means a very deep voice. So they're unable to change their voice to have a higher frequency. So you know how usually you have a deep voice for men and then like more shrill voice for women. Not always, but like in general. So men will be unable, or the person that loses this will be unable to have to increase the frequency. So they won't be able to have a shrill voice. They won't be able to increase like a squeaky voice. That will be gone. They'll have a very deep voice. And that is due to the external laryngeal nerve damage, which supplies the cricothyroid and is related to the superior thyroid at its origin. And we'll go back to the diagram once again so we can see these things. And then we have the other nerve, the recurrent laryngeal nerve. It runs in a groove between the trachea and esophagus. And if you guys remember, I told you the inferior thyroid artery also runs in this same groove. So they run in the groove together. During the ligation of inferior thyroid artery, we may accidentally damage this nerve, and it's responsible for all the intrinsic laryngeal muscles. So basically every muscle in the larynx, except the cricothyroid, because that was supplied by external laryngeal. And it's also responsible for the sensory innervation of the larynx. So if we have loss of this nerve, it may cause hoarseness, which is basically a raspy and hoarse voice, which you can see in some people that have like laryngeal cancer and they have the larynx removed, or like that smoke a lot. So basically, you may ask me why, if it's responsible for every muscle, then why don't we like why can't we if this nerve is damaged, then technically we shouldn't be able to speak. And that is correct. But the thing is that we have two of these nerves, one on each side. So the likelihood of both being damaged is low. So if one is damaged, then we have hoarseness because the other nerve, only one side of muscles are working and the others aren't. That's why we have hoarseness and like a raspy voice. So the recurrent laryngeal nerve actually has this difference, and the right one wraps around the subclavian artery, and the left one wraps around the arc of aorta, and this is basically arch of aorta, and this is basically due to the embryological origin. And I think you'll study it later. I'm not going to get into it now, but basically because of how the embryological arches, there's arches of the aorta embryologically, the different arches, and it's basically because of that the difference. So the right one wraps around the subclavian, and the left one wraps around the aorta arch. And this is because obviously we have the heart on the left side. So that's why you have this difference. Um, so basically, this is the superior laryngeal nerve, okay? And this is the recurrent laryngeal nerve. The superior laryngeal nerve is the same thing as the external laryngeal nerve. It's just a different name. I know this can get confusing, but the external laryngeal and superior laryngeal are the same thing. Perhaps it would be easier for you to remember superior laryngeal because superior laryngeal also is in close contact with superior thyroid, so that makes it easy, superior and superior. But yeah, they're the same thing. And then recurrent is in contact with inferior thyroid, right? So this is superior laryngeal nerve over here, and then this is the superior thyroid artery, and you can see how close they are at origin. This is just originating, and then they cross over. So while we're ligating over here, we could damage the nerve. And then recurrent laryngeal, you see how it's running, and then we have this inferior thyroid artery. You can see they don't immediately, like the inferior thyroid runs a bit in its course, and then they intersect. So that's the difference between them. And so a very important thing is ligation points. So for the superior thyroid artery in a surgery, where we're ligating it, we should ligate it near to the superior pole of the thyroid. So the reason for this is because the external laryngeal nerve or the superior laryngeal nerve is in contact with the superior thyroid artery at origin. So right as it originates, that's when they cross over, right? Like they cross over here. So we would let this run until we reach the superior thyroid here, okay, the superior pole, and then we would ligate it, okay? So not at origin. But for the inferior thyroid, it's the opposite. You ligate it as soon as it originates from the thyrocervical trunk, since the recurrent laryngeal nerve runs with it in the groove between esophagus and trachea. So you can see here, we have like this distance before they intersect. So you would want to ligate it over here to avoid the risk of damaging it over here. Because if you try and ligate it over here, you still have risk of damaging the recurrent laryngeal. So you want to ligate it as soon as it originates. But it's the opposite for the external laryngeal or superior laryngeal. You want to ligate it all the way at the thyroid and not at origin because that's when it crosses over with the superior laryngeal nerve. Okay, so venous drainage is quite simple. There's a superior thyroid vein, a middle thyroid vein, and an inferior thyroid vein. So the superior one drains the superior poles, the middle one drains the lateral parts, and the inferior one drains the inferior poles. So quite simple. But what isn't as simple is where they drain into. So the superior thyroid and the middle thyroid empty into the internal jugular veins. And I'll show you in the diagram, and it's going to make a lot of sense when you see it there. But just remember that the superior thyroid and middle thyroid empty into the internal jugular, and then the inferior thyroid empties into the brachiocephalic vein. Okay, so I'm going to go back to this diagram because it's useful. Okay, so once I'll go over it one more time. But the superior thyroid artery over here, the the nerve, external laryngeal nerve or the superior laryngeal nerve is going to cross over here. So that's why you want to ligate all the way over here. So you don't damage the nerve that's running over here. But it's the opposite for the inferior thyroid because you see this course that is taking over here. It's going to be accompanied by the recurrent laryngeal nerve. And that's why you want to ligate it as soon as it originates. Okay, now we go back to the veins. The superior thyroid vein is this one. So as you can see, it's at the superior pole, and it's going to drain the superior pole and go into this structure right here, which is the internal jugular vein. The middle thyroid vein does the same thing. It drains the lateral parts and then drains into the internal jugular. So you can see it makes more sense now why we say internal jugular, why we say it's draining into the internal jugular, because it's right there. It's like just lateral to it. But for the inferior ones, the inferior thyroid veins drain into this structure right here, which is the brachiocephalic vein, right? And the reason for this is because of like it's more like it's it's close to it. It's easier for the inferior thyroid to go like straight down than to take this route. So that's why it drains into the brachycephalic. So superior thyroid, middle thyroid into the internal jugular, inferior thyroid into the brachycephalic, right? And then these two merge and form the vena cava, or whatever. Okay, so now we go to lymphatic drainage, which is again, it's not that important, but there's one specific thing that's very important. So they run in the interlobular connective tissue, often around the arteries. So they're basically running the same course as the arteries. They're around them. And some lymph vessels of the thyroid drain into the prelaryngeal, pretracheal, and paratracheal lymph nodes. So there's three sets of lymph nodes, right? Actually, there's four, but these are three of them, and they're all somewhat related to the trachea and the larynx, and that's why they're named prelaryngeal, pretracheal, and paratracheal. The lateral lymph vessels, which drain the lateral parts, drain into deep cervical lymph nodes, and this is important because the deep cervical lymph nodes are the most common path for spread of cancer cells. So if there was to be a cancer of the thyroid, basically the most likely way for it to spread would be through the deep cervical lymph nodes. And some lymph vessels just directly drain into the brachiocephalic lymph nodes or into the thoracic duct. And this is better explained on this diagram over here. So these are the brachiocephalic lymph nodes that we talked about. Okay, this one over here. Brachiocephalic because it's right next to the brachiocephalic vein, right? So some of the lymph vessels will drain directly into this. Okay, some of them, the lateral ones, will drain into the deep cervical lymph node. So there's two parts. There's a superior deep cervical and an inferior deep cervical, and they're on either side of this muscle, which is the sternocleidomastoid. You don't need to know that, but like this and this, deep cervical, right? Uh, they're not gonna ask you to recognize them. I just thought it would be better for you to have the image in your mind. And then the rest of them drain into prelaryngeal, pretracheal, and paratracheal. So what does that exactly mean? Prelaryngeal means right in front of the larynx, and that's what you can see there in front of the larynx. We have pretracheal, which are in front of the trachea in the midline, and then we have paratracheal. Paratracheal means around the trachea. So just lateral to the trachea, we see these ones over here. Those are paratracheal. The ones directly in front of the trachea are pretracheal, and then the ones in front of the larynx are prelaryngeal. So these are the different types of nodes that are present. The most important one is deep cervical because this is like the most common path for this sort of cancer. But then the other ones, you should know them as well, but they're not as important. Okay, so we're done with all of anatomy, and now we have histology. So this is quite easy. It's, as I said, it's surrounded by a dense, irregular CT capsule, connective tissue, which is the true capsule that's present right next to the thyroid. And then outside that, we have the false capsule, also known as the pretracheal fascia, which connects the thyroid gland to the trachea. And then the parathyroid glands are embedded within this capsule. So as I said earlier, the parathyroid glands are posteriorly attached to the thyroid, and they're attached to this true capsule. It's the same one as the one we took at the start of the lecture. The capsule sends septas into a lobe, and then it makes lobules. I don't know what it's containing here. That's a mistake for me. But it basically sends these septas into the lobe and divides the lobe into lobules. And then each lobule has follicles, right? So there's 300 follicles in a typical thyroid gland. So a whole thyroid gland has 300 follicles. And then the septas, other than making lobes, they also have another function that is making pathways for blood vessels, lymphatic vessels, and nerves, right? So basically, they make a pathway for these structures to move in. We have two types of cells within the thyroid, which is the follicular cell and the parafollicular cell. And we'll in the next slides, we'll know what they do, but the parafollicular cell is also known as the C cell because it releases calcitonin, and C for C. That's why they named it C cell. Okay, so I have a diagram which is going to make it easier. So F is the follicle, right? That's present. There's 300 of these in a typical thyroid gland. And then S is the septa. So these structures over here are septas. They're sent in by the capsule to separate them into lobules. So this whole structure is one lobule. And then this septa separates it from the next lobule. And then this septa separates it from the next lobule. So you can see how it's making lobules, right? Okay, so now we have the follicles that we talked about that are these, right? So the spherical structure is filled with colloid, which is mostly ironated thyroglobulin. So the colloid, which is present within these follicles, is ironated thyroglobulin. Okay. And we'll know what this is in a bit, but just remember for now that the thyroid follicles have thyroglobulin. So ironated thyroglobulin has T3 and T4, which are the thyroid hormones attached to it. T3 is triiodothyronine and T4 is tetraiodothyronine, also known as thyroxine. And or if it doesn't have these attached to it, it has the precursor for these hormones attached to it. So basically, that's what's attached to the thyroglobulin. The thyroid follicles are surrounded by follicular cells, quite obvious by the name. And then these follicular cells are in turn surrounded by parafollicular cells, which also makes sense because para, as I said earlier, means around. So these parafollicular cells are around the follicular cells. They both rest in the basal lamina, which separates them from the abundant network of fenestrated capillaries in the connective tissue. So we have fenestrated capillaries for the blood supply in the connective tissue, but we have a basal lamina that separates the follicular cells from that separates the follicular and parafollicular cells from the other structures. So what do the follicular cells do? They synthesize and store the thyroid hormone that are T3 and T4, and then they secrete them as well later. And then the parafollicular cells release calcitonin, which regulates calcium metabolism, and it's basically an antagonist to the parathyroid hormone. I think there's a separate lecture for that. But basically, I think calcitonin increases calcium in blood and parathyroid hormone does the opposite. So basically, they're antagonists. So parafollicular releases calcitonin, follicular releases thyroid hormones. And then parafollicular are also called C cells because of their function. So this is a really nice diagram. This is one lobule. You can tell because it's separated by the septa on either side. Then we have follicles within this lobule, right? Like these follicles are within the lobule. And then within the connective tissue, we also have arteries and like um, other blood vessels. I think this is a blood vessel right here because you can see the red, which is the red blood cells, but I'm not sure on that. So don't quote me on that. But like other than that, this is the lobule follicles within it, and then the connective tissue, which separates them. So the follicular cells, we said that they secrete thyroid hormones, and they're normally cuboidal in shape. So the epithelium that surrounds them is cuboidal, right? So they have cuboidal epithelium. But when stimulated, they become columnar, and when inactive, they become squamous. So the way I like to remember this is normally they're cuboidal, and then if they're stimulated, they have to do more work, so they become bigger, which is columnar. And then if they don't have to do any work, when they're inactive, they become lazy and become squamous. So they shrink and become squamous, right? Because squamous is the smallest. So follicular cell, they also contain many apical vesicles involved in transport and release of thyroglobulin, and will in the formation of thyroid hormone, we'll study more about this, but they have these small vesicles at the apical surface that are involved in the transport and release of the thyroglobulin from these cells to the blood, to the other side. We'll study about this in a bit, so don't worry about it right now. Now we have an inactive follicle and an active follicle. So as I said earlier, there's two different types, columnar and squamous. So an inactive one is squamous epithelium, and an active one is columnar epithelium. But there's another difference. So an inactive follicle is going to have a large amount of thyroglobulin. And the reason for this is because if it's inactive, then the thyroglobulin hasn't been used to make T3 and T4. It's unused, so there's a large amount of it. But if it's active, then there's a small amount of thyroglobulin, which means it's been used up earlier. So that's why it'll be a small amount. I think it's easier to understand over here. This is inactive. You can see it's very large. Okay. You can't really tell the type of epithelium here because the magnification isn't high enough, but you can tell that this is super large and then this one is super small. So the small one is active because it's been used up, and the large one is inactive because it hasn't been used up earlier. But you need to remember that the inactive one is squamous because it's lazy and shrank, and then the active one is columnar because it's more active and it grew from cuboidal to columnar. But the normal follicle, which is just like in between, is going to be cuboidal in shape. So we're done with anatomy and histology. And now we come to physiology, which is the longest part of this lecture, and probably it's not difficult, but it's like long. So I'll try and make it easy for you guys. So let's go. So the thyroid gland secretes two hormones, T4 and T3. T4 is tetraiodothyronine, and then T3 is triiodothyronine. T4 is also called thyroxine. That's a common name for it. So how does it happen? So the pituitary gland secretes this thing called thyroid stimulating hormone, which you guys must have already studied earlier. And this basically regulates thyroid secretion, thyroid hormone secretion from the gland, right? The thyroid gland also secretes calcitonin, which helps in calcium metabolism. And the structure is very simple. So the T4 has a tyrosine ring, tyrosine, the amino acid, with four iodines attached to it, and that's why it's called T4. Like it's literally in the name, T4. And then T3 has a tyrosine ring with three iodine attached to it, and that's why it's called T3 because it's tyrosine with three iodine. So that's in the name again. T3 is actually more active than T4. It's about 4 times more active, but it lasts shorter than T4. So it has less half time, basically lasts less in the blood. But it binds with the nuclear receptors with greater affinity, which means basically when these T3 and T4 go to cells and they go to the receptors, the T3 is going to bind more strongly than the T4. But the T4 actually lasts longer, and it's the major secretion of the thyroid gland. So 93% of the hormones that are secreted by the thyroid gland are T4, and only 7% are T3. So once again, T3 is more active, but it lasts shorter, and it binds with greater affinity. But T4 is much more abundant and lasts longer, right? The tissue converts the T4 to T3. So when the thyroid hormones go to the peripheral tissues, they have this enzyme called 5' deiodinase. And it's in the name. What does it do? It removes an iodine, deiodinase. So it makes T4 into T3. And the reason it does this is because obviously T3 is more active and also binds with greater affinity. But T4 is the major form in blood. So that's why it's going to be converted at the peripheral tissues. I hope that makes sense. We also have something called reverse T3, which is similar to T3, but there's different iodine attachment sites on the tyrosine ring, right? There's a tyrosine ring. So there's different attachment sites, and that's why we have something called T3, which is useless because it has no biological activity. So it's basically just, and it's just there. There's nothing, it has no function. So the synthesis is an 8-step process. It can be a bit confusing, but hopefully I've tried to narrow it down from what was in the lectures to only focus on something that's important, and it's all in caps because this is only the important stuff, right? So the first step is over here. So 70 tyrosines are going to merge and form thyroglobulin. Okay. So these 70 tyrosines are going to merge. They're going to form one big structure called a one thyroglobulin, and then this is going to pass from the follicular cells into the lumen. So the follicular cells are obviously around the lumen or in the follicle itself. But yeah, it passes and goes into the follicular lumen through passive transport, maybe like through a transporter, but there's no active transport or like specific ion channel um, associated with it. So that's the first step. The second step is we have something called a sodium iodide transporter. So I minus, this I minus is iodide, okay? And the I2 is iodine. So these are different chemical variants of the same molecule, but like I minus is iodide. So we have the sodium iodide symporter, which is this NIS, which transports iodine into the cell against the concentration gradient inside the cell. So we already have a lot of iodine inside the cell, but the whole function, the whole point of this cell is to form thyroid hormones, and we need iodine for that, right? So that's why it transports iodine against the concentration gradient along with sodium because it's a symporter. And then we have something called pendrin, which transports iodide into the follicular lumen. So like this iodide, once it enters the follicular cell, it's going to go into the lumen via this pendrin. And what is pendrin? It's a chloride iodide antiporter. So basically, the chloride that's present in the lumen is going to be pushed into the cell, and then the iodide in the cell is going to be pushed into the lumen. So it's like an antiporter. So opposites, right? So the iodide concentration in the cell is actually 30 times more at basal activity, which is just the base. And then when it's producing the maximal amount of thyroid hormones, that time it's 250 times more than outside the cell. So as I said, the concentration gradient is within the cell. So still there's more iodide in the cell than there is outside, obviously. And all of these transporters are stimulated by thyroid stimulating hormone. And if you think about it, that makes sense because if the thyroid stimulating hormone is released, that means it wants thyroid hormones, right? And then thyroid hormones are formed via these steps. So anything that upregulates this or like makes it easier or makes more of it is going to be stimulated by the thyroid hormone, by the thyroid stimulating hormones, right? So the NIS obviously it brings iodide into the cell, and the pendrin brings iodide into the lumen. So both of these will be stimulated by the TSH just because the TSH wants maximal thyroid hormone, right? And then the sodium iodide symporter, which is NIS, is helped by an ATPase. This one, the sodium potassium ATPase, because this removes sodium from the cell. And the reason that this is important is because the sodium iodide symporter also brings sodium into the cell. And we can't have too much of the sodium within the cell because we need to maintain this concentration gradient, right? So the sodium is removed from the cell by this ATPase and then brought back in by NIS just to maintain the gradient. So this is important as well. Okay, the third step is the conversion of the iodide into iodine by iodine peroxidase. And this takes place in the follicular lumen. If you follow the diagram, this is going to be super simple because the iodide is brought in by the pendrin and then it becomes iodine. And the enzyme responsible for this is iodine peroxidase. And this process is called oxidation. Okay. Iodine peroxidase. Remember, it's very important. It's going to be, we're going to study about it in the next few slides as well. So in the fourth step, those are the first three steps. And now we have thyroglobulin and iodide in the lumen. So the fourth step is that the iodine peroxidase, the same enzyme, catalyzes the addition of iodine to thyroglobulin, forming MIT and DIT. Not MIT, the college. MIT is monoiodothyronine, and DIT is diiodothyronine. So basically, MIT or monoiodothyronine is one iodine connected to one tyrosine. Actually, not one tyrosine, one thyroglobulin. Uh, no, I apologize. This is correct. Monoiodothyronine is one iodine connected to one tyrosine. So the thyroglobulin is made up of 70 different tyrosines, right? So when one iodine connects to one tyrosine, we have MIT. And then DIT is two iodines, two I2s connected to one tyrosine. That's what we call DIT. And this whole process is obviously is catalyzed by iodine peroxidase, the same enzyme that's responsible for the oxidation of I minus to I2. So at this point, what we're left with is a thyroglobulin with an MIT and a DIT attached to it because the iodine is connected to the tyrosines within the thyroglobulin, right? The fifth step is the same peroxidase, iodine peroxidase, causes coupling, which is basically it adds these two structures together. So an MIT and a DIT, which are these two structures over here, are going to couple and form T3. And this makes sense because MIT has one iodine, DIT has two iodine, and when they add together, they have three iodine, right? Which is T3 because it's triiodothyronine. And then if we have two DITs that couple, then we have T4, which obviously makes sense. So di means two iodine and then two iodine, and then we add them, we have T4, which is tetraiodothyronine. So basically 1 plus 2 is 3 and 2 plus 2 is 4. So basically just math. So one thyroglobulin can actually store up to 30 T4 molecules and a few T3 molecules, like 3 or 4, in storage. So this thyroglobulin over here, you see, this can store 30 T4 and like 3 or 4 T3. And as I said earlier, T3 is not as important because it's just a minor secretion from the gland. Most of the secretion is T4 and then it's turned into T3 peripherally by 5' deiodinase. So the thyroglobulin can store these, and this is enough for a 2 to 3 month supply. So basically, what that means is if you were to completely shut down the thyroid gland, for, like the activity for 2 to 3 months would be okay because like we have a reserve of these. But then after the reserve is over, then we need to synthesize new ones, right? So a note here is that the thyroglobulin is not released in the blood. So this thyroglobulin, which has all these T4, T3, and then MIT, DIT, all of this, these T4, T3 are secreted into the blood, but the thyroglobulin is not usually secreted into the blood, right? So so that's not normal for it to be there. Now we have this step, which is endocytosis of the thyroglobulin with the T4, T3, MIT, and DIT attached to it. So you might ask me, why is there MIT and DIT? Didn't they couple in step five? Or was it step four? Whatever, step five, I think. Wait, step five, right? They coupled. And this is because not all of the MIT and DIT are going to couple. Most of it will, and this was from T4 and T3, but some of it will just remain as MIT and DIT connected to the thyroglobulin. So now we have this thyroglobulin with T4, T3, MIT, and DIT attached to it. It's going to be endocytosed back into the cell from the lumen. The seventh step is, so now we have this thyroglobulin with T4, T3, MIT, and DIT in the cell, right? But they're still connected to the thyroglobulin. So we're going to have the TSH come and bind to the basal membrane. The thyroid-stimulating hormone released by the anterior pituitary is going to like go to the basal membrane of the follicle and going to bind there. And basically what this does is it activates these vesicles, okay? These vesicles that are present in the lysosome, right? The lysosome obviously has proteolytic enzymes and all other kinds of stuff. So once it activates the vesicles, these vesicles go to the lysosomes and release these proteolytic enzymes. These proteolytic enzymes are then going to act on thyroglobulin with the T4, T3, MIT, and DIT attached to it, right? So it's going to break down this thyroglobulin, and then we're going to have free T4, free T3, free MIT, and free DIT, right? So the free T3 and T4 are going to leave the cell and then enter blood circulation, but the MIT, DIT do not. The thyroglobulin also, as I said earlier, does not enter blood circulation because it's broken down. So what happens to the MIT and DIT? That's the last step. The MIT and DIT after proteolysis are broken down by deiodinase enzyme, the same deiodinase that we studied about earlier that takes T4 to T3. And again, this makes sense because MIT is monoiodothyronine, which is one iodide connected to one tyrosine. Right? One iodine actually connected to one tyrosine. So deiodinase is going to remove the iodine and basically recycle it. So the same for DAT, diiodothyronine, is going to remove two iodines, and then recycle them. And that's exactly what it does. It's recycling. And you can see here, MIT and DIT are recycled by deiodinase. So the iodine part of them goes back to the cell, and then it goes through the whole pendrin pathway again. And then the tyrosine part of them basically just joins again to form thyroglobulin. And then the whole cycle is repeated again, right? So that's their cycling part. So now what would happen if we do not have deiodinase, right? So we wouldn't be able to recycle the MIT and DIT, and this would lead to a thyroid hormone deficiency because we are wasting all this iodine and tyrosine. It's all being wasted. So that's not useful. That we don't want that. So let's go over it one last time because this is very important. So this is a big diagram. I'll just go over it again. We have the NIS, which is a symporter. It brings iodine into the cell. 70 tyrosines join to form thyroglobulin. The thyroglobulin goes into the lumen via just like passive diffusion. The second part is that we have this NIS, sodium iodide symporter, which brings both of these into the cell. The third step is this iodide, which is brought into the cell by pendrin. It goes out of the cell, and then we have the fourth step, which is basically the iodine peroxidase. It transforms it into I2. Then the fifth step is that the iodine peroxidase catalyzes the formation of MIT and DIT. And then the next step, again, iodine peroxidase. So three steps use iodine peroxidase. It's going to cause coupling, which forms T4, T3 from MIT and DIT. We also have some spare MIT and DIT that do not couple. Then we have endocytosis of this thyroglobulin molecule with all of these things attached to it into the lumen, into the cell, sorry, from the lumen. And then when TSH binds, we have the vesicles that go to the lysosome. The lysosome releases enzymes, and the enzymes break down this thyroglobulin into T4, T3, MIT, DIT, right? The T4, T3 will then leave and go into the blood. The MIT and DIT will be recycled using the eighth step, which is the deiodinase enzyme. The iodine is going to, again, go through pendrin outside again, it's going to be recycled, and the tyrosine is going to form thyroglobulin. So it's also recycled. So that's how everything is recycled. And that is it for. I hope you guys understood this. You need to go over the diagram multiple times because it's one of the most important things in this lecture. And hopefully the rest of the stuff should be easy after this. It's just hypo and hyperthyroidism, which is like, you're going to understand it easily, inshallah. Now we have inhibitors of the synthesis. So what if we want to stop this? So there's two drugs, propylthiouracil and methimazole. They both inhibit iodine peroxidase, which is, and these drugs are used in cases of thyrotoxicity. So thyrotoxicity is when we have too much thyroid hormones, and we don't want extra because it has obviously harmful effects on the body. So we want to stop this synthesis and formation of T3 and T4. We'll use these drugs. Okay. Propylthiouracil and methimazole. People also abbreviate propylthiouracil to PTU, so you must remember that. So these two drugs inhibit iodine peroxidase, which is obviously one of the most important enzymes. It's used in 4 steps, 3 steps here, here, and then in coupling as well. So basically, if you stop it, you can't form the thyroid hormones. And then the PTU also has an additional function, which is that it inhibits 5' deiodinase in peripheral tissue. So as you can see in the diagram, there's a peripheral tissue, and then it basically inhibits this 5' deiodinase. And the reason that this is useful is because obviously deiodinase takes T4 and makes T3, right? Which is more active and more useful. So this blocks that. So PTU and methimazole block iodine peroxidase and also block deiodinase in peripheral tissues only. It does not block this deiodinase. This deiodinase is not peripheral. It's at the thyroid gland. It only blocks the peripheral ones. Okay. Now we have the regulation. I think I'm just gonna explain it on the diagram. Last year, the third lecture was much longer. It was about 60 slides, but for you guys, it's only 40 slides. So they moved a lot of slides. I don't know if they added it to a different lecture or if they just like completely cut it. But like, uh, I'm teaching you whatever was in the new lecture, which is your lecture. I haven't added anything from last year's lecture. So we have the hypothalamus, right, which is in the brain, in the cerebrum, and it releases something called a thyroid releasing hormone, right? The thyroid releasing hormone is going to stimulate the anterior pituitary or the adenohypophysis to release something called TSH, which is thyroid stimulating hormone. Thyroid stimulating hormone is going to stimulate the thyroid follicular cells to release T3 and T4, which are the thyroid hormones. And then the T3 and T4 are going to perform their functions on the effector organs, right? This is all very simple. We also have negative feedback. The T3 and T4, the thyroid hormones, are going to go and inhibit the hypothalamus from releasing TRH because it has enough of this, right? We also have the anterior pituitary. When it releases TSH, it's also going to inhibit the hypothalamus because khalas, it releases the TSH. It doesn't need any more because more is harmful, less harmful. Like we need the right amount. And then somatostatin also inhibits anterior pituitary. This is not that important, but like you might want to do it just in case. You might want to know it. And then we have something called TSI, and we're gonna leave it for now because we have like 3 slides dedicated to this in particular. So hypothalamus TRH stimulates anterior pituitary, which forms TSH, which stimulates follicular cells, which releases T3 and T4, which causes effects in the organs. And then T3 and T4 inhibits hypothalamus, and anterior pituitary also inhibits hypothalamus. And then somatostatin inhibits anterior pituitary. So that's it for the regulation. Now, what do the thyroid hormones do? We said they have a function. Where is the function? So there's an easy way to remember this, and it's the 6 Bs, right? B, brain maturation. B, bone growth. B, beta adrenergic effects. B, basal metabolic rate increase. B, blood sugar increase. And B, breaks down lipids. So 6 Bs are its 6 functions. Brain maturation. So basically, the thyroid hormone has a function that is responsible for CNS maturation, right? Bone growth. So it's synergistic with the growth hormone. And synergistic basically means it works in tandem with the growth hormone. So they both work together to form the bone, to increase bone density and size. So basically bone growth. Beta adrenergic effect, it increases the beta 1 receptors in the heart. And This increases cardiac output, heart rate, stroke volume, and contractility. Basically, it has a positive inotropic effect, which you guys did in CDP. So that's another function. It increased the basal metabolic rate, and this is the BMR. So basically, what that means is it increases the O2 consumption of the body, which obviously increases the body temperature because of the mitochondria, and then also increase the respiratory rate because we're taking in more O2, right? So that's what BMR is. It increases that. We have an increase in blood sugar because it stimulates glycogenolysis and gluconeogenesis, which is breakdown of glycogen and formation of glucose. So that's why it increases blood sugar. And then it also breaks down lipids, so it causes lipolysis. Okay, so these are the 6 functions that you need to know. Uh, Very important to know these. And the 6 Bs actually makes it much easier because you just think BBB, BBB, and like that's it. So we're done with everything except the diseases. So we're almost done. I know this has been a bit overwhelming because it's a lot of information. Honestly, I understand that, but it's also very easy. That's the thing. So we're at the last part of the lecture, which is the diseases. There's 2 types, hyper and hypo, and we'll go over them. So hyperthyroidism basically means an increase in T3 and T4. And there's different ways that this can happen. Something that you must avoid at all costs is thinking that hyperthyroidism is an enlarged thyroid, because you can have an enlarged thyroid and hypothyroidism as well. It has nothing to do with the size of the thyroid. Like particular diseases might have an increase in thyroid size, but hyperthyroidism in general does not cause an increase in general. But it does cause an increase in T3 and T4. That's why it's called a hyperthyroidism. And another name for this is thyrotoxicity. So the first one is the most important one, which is Graves' disease. So we have autoimmune disease. This is an autoimmune disease that causes there to be an antibody called a TSI, which is a thyroid stimulating immunoglobulin, right? So these thyroid stimulating immunoglobulins bind to the TSH receptors. So they mimic TSH and induce nonstop activation. So TSH obviously causes activation of the thyroid follicles to release T3 and T4. And TSI does the same thing. It binds to them nonstop. It does not stop. And it basically induces activation all the time. So this leads to a decrease in TSH. Can you tell me why? It's because TSH has negative feedback from T3 and T4. If TSI is continuously stimulating the thyroid gland to release T3 and T4, we're going to have a lot of T3 and T4, right? Which is in turn going to have negative feedback and decrease TSH. So this antibody basically mimics TSH and then causes nonstop activation. So in Graves' disease, we're going to have high TSI because that's what causes the disease. We're going to have low TSH because of the negative feedback by the high T3 and T4. We're going to have high T3 and T4 because of the TSI, which stimulates the thyroid cells. We're going to have something called exophthalmos or proptosis and lead lag. And just remember this for now. There's the next slide is going to deal with this exophthalmos and lead lag. Then we have something called thyroid adenoma, which is a cancer of the thyroid. And obviously, this causes an increase in the size of the thyroid gland because it is a cancer. And the healthy part of the gland, which is not affected by the cancer, will show a reduction in thyroid hormone secretion because of negative feedback. So again, in thyroid adenoma, we're going to have increased T3 and T4 from a particular section of the thyroid gland, which has this cancer. The healthy part, which does not have this cancer, will show reduction in thyroid hormone secretion, but overall there will be an increase in T3 and T4 and a decrease in TSH again because of negative feedback. We may also have pituitary adenoma, which could lead to hyperthyroidism. You already studied about this, right, in the pituitary gland lecture. And basically, this is a thyrotropic adenoma. It affects the cells that release TSH. So we're going to have an increased release of TSH, which is going to excessively stimulate the thyroid gland to release excess T3 and T4, right? So in this case, in the other 2 cases, you had a decrease in TSH because of the fact that there's negative feedback. But in this case, you're going to have increased TSH because that's what's causing the disease. You're going to have decreased TRH, which is thyroid releasing hormone, because remember, the anterior pituitary TSH is going to cause negative feedback to the hypothalamus to decrease the release of TRH. But you're going to have an increase in T3 and T4 as well. So one last time, in Graves' disease, we're going to have high TSI, low TSH, high T3, T4, exophthalmos, and lead lag. In thyroid adenoma, we're gonna have high T3 and T4, but low TSH. In pituitary adenoma, you're gonna have high TSH, high T3 and T4, but low TRH. It's very important that you understand this, and like instead of remembering it, you need to understand it. That's gonna make it much easier for you because once you understand it in like with the pathways, it's gonna be super easy. So the symptoms of hyperthyroidism are as follows. So remember the function of thyroid hormones. Remember the six B's. Just remember them. So high state of excitability is also known as anxiety, and this is because, as I said, the T3 and T4 act on the CNS, the first B, brain maturation. That's why you have this. Intolerance to heat because of increased BMR, which is one of the B's, right? Because BMR is going to cause increased sweating and stuff. So you're going to have the BMR is basically going to increase your temperature, the body temperature, which means it's going to be harder for you to tolerate the heat. Increased sweating because of increased sympathetic activity. So the thyroid hormones do cause an increase in sympathetic activity. This was not mentioned in the six B's, but it's something that you should remember. Weight loss, I guess, again, because of increased BMR, is going to cause an increase in body temperature and hence cause a decrease in an increase in weight loss because you're using more energy, right? You're going to have diarrhea. You're going to have muscle weakness, nervousness. Again, this is related to the T3 and T4 action on the nervous system. You're going to have fatigue accompanied with insomnia, which is basically the inability to sleep. So even though you are sleepy and tired, you cannot sleep. That's what insomnia is. You're going to have hand tremors. Again, this is related to the CNS. You're going to have an increased heart rate and blood pressure. You know why? Because they act on the heart, right? One of the B's was beta 1 adrenergic receptors, right? So, but this may not be as pronounced because of compensation via other mechanisms that the heart has, like to reduce the heart rate and blood pressure, vasodilation and stuff. But yeah, it would cause an increased heart rate and blood pressure. So these are the things that you would see in a patient that's suffering from hyperthyroidism, right? Now, I said earlier exophthalmos and lid lag. What exactly is that? So first of all, I said there were two words there. One was exophthalmos and the other was proptosis, and you're gonna find these two words in the lecture. So exophthalmos is proptosis of the eye. Proptosis is basically protrusion of any part of the body, but exophthalmos is in particular protrusion of the eye. So exophthalmos is protrusion of the eyeball in people with hyperthyroidism. So this is basically what a normal person would look like, right? Like, and then this is what exophthalmos is. You see the eyes are like protruded, the eyeballs are protruded. They're like basically like think of the cartoon with like when someone surprises someone and then you have the eyeballs popping out. That's basically what exophthalmos is. And the reason for this is you're going to have edematous swelling of retroorbital tissue, which means behind the eye, swelling of the tissue, and you're going to have degeneration of the extraocular muscle. So the muscles around the eye are going to degenerate, and then you're going to have swelling behind the eye, and both of these factors are going to push the eye outwards, right? And the degeneration is because of some IgGs reacting with eye muscles. And IgGs are basically a type of antibody that react with the muscles and destroy them, degenerate them, which causes this. And this is commonly seen in Graves' disease. You're going to have this IgG antibodies in addition to the TSI, thyroid stimulating immunoglobulins, right? And then lid lag is due to the degenerative muscle changes. So this is the good example of lid lag over here. Basically, the eyelids are going to be retracted. They're going to be higher up than usual, and the pupil and I forgot what the things in the eye are called, but the pupil is going to be pointing downwards, right? So basically, this is lid lag. So how do you diagnose and treat hyperthyroidism? You should already know the diagnosis part. It's super simple because obviously if you have hyperthyroidism, you're going to have increased free thyroid hormones, so increased T3 and T4. You're going to have increased BMR, again, it's one of the B's. You're going to have low TSH because of negative feedback, unless you have thyrotropic adenoma, in which case you're going to have increased TSH because it's a pituitary gland tumor that's going to secrete more TSH, right? So this is true for every disease that causes hyperthyroidism except this pituitary adenoma. You can have high TSI in Graves' disease. This should say Graves, I'm sorry. And this is only in cases of Graves' disease, right? Because TSI is related to Graves' disease. It's an antibody that causes Graves' disease, right? So how do you treat it? And the most common way of treating it is just removing the thyroid gland. And because even if we remove the thyroid gland, we can just give thyroxine injections, so it's not as important. So 1 to 2 weeks before the procedure, we give PTU to decrease the metabolic activity of the patient. I hope you remember what PTU is. It's propylthyroid uracil, which blocks the iodine peroxidase and 5' deiodinase in peripheral tissues, right? So this decreases the metabolic activity of the patient before the thyroid removal, thyroidectomy, right? Or the other option is radioactive iodine at 5 millicurie, which is the dosage. You don't need to remember that. Will destroy the thyroid cells. So the radioactive iodine is going to be taken up by the thyroid. It's radioactive, so it's going to destroy the cells. It's as simple as that. And you keep repeating this until all the cells are dead. So that's how you treat hyperthyroidism. Okay, so we're done with hyperthyroidism. We're done with Graves' disease, which is very important. Now we have hypothyroidism, which is it's basically the opposite of what happens in hyperthyroidism, and this is also the last part of the lecture. So I'm sorry that it's taking so long, but this is the last part. So we're gonna have a disease called Hashimoto's disease, and this is a general rule in medicine. Whenever you see a disease that's named after a person, it's usually important. So like Graves and Hashimoto are the two most important diseases that affect the thyroid gland. So its antibodies against thyroid peroxidase will attack and will destroy the gland rather than stimulating it. It's not the same as TSI. TSI would bind to the TSH receptors and stimulate the gland more than it should be. But these antibodies are different. They basically destroy thyroid peroxidase, which is the same as iodine peroxidase. It's the same enzyme. It's just a different name for it. And it destroys the gland. It doesn't overstimulate it, it just destroys it. So it results in inflammation and deterioration of the thyroid gland. You're going to have fibrosis, which is obviously because of the deterioration and destruction. Fibrosis is always going to be seen when you have destruction. And then you have greatly reduced secretion of T3 and T4 because the gland is being destroyed, right? Then we have another disease called endemic colloid goiter. And this is because of dietary iodine deficiency. And this is common in underdeveloped countries. You're going to have less iodine, okay? You're going to have low T3 and T4 because we need iodine, right? For the formation of the thyroid hormones. Remember all the 8 steps, you need iodine. So if you have low T3 and T4, you're going to have increased TSH, right? Because there's no negative feedback. So TSH is going to increase. If TSH increases, it's going to go to the thyroid follicle, it's going to stimulate them, and this is going to lead to increased thyroglobulin and enlarged follicles, right? Thyroglobulin, if you guys remember, is 70 tyrosines. It does not require any iodine, right? So it's going to keep increasing. It doesn't need iodine. So basically what the brain thinks is wrong is that there's low T3 and T4, so I need to stimulate them to make more. What it does not realize is that we don't have iodine, so we can't make no matter how much you try. So what it does is it's just going to increase the thyroglobulin, which is present within the follicles, and these follicles are going to enlarge, obviously. And that's why you have goiter, which is basically enlargement of the thyroid. It's because of this pathway over here. I hope that's clear. And then we have idiopathic non-toxic colloid goiter, which is also goiter, but it's not the same mechanism as this. This is because of less iodine and then this whole pathway. This is associated with thyroiditis, which is inflammation of the thyroid gland that leads to a decrease in size of thyroid gland at some areas. Now, what exactly causes this? We do not know. That's why it's called idiopathic. Idiopathic basically means when you don't know something, when you don't know the reasoning for something, you call it idiopathic. So it's idiopathic because you don't know why this happens, but it happens and it causes a decrease in size in some areas, which leads to a decrease in T3 and T4. Like that's intuitive, that's obvious. You're gonna then have an increase in TSH because there's no negative feedback. And this TSH is going to stimulate the particular thyroid parts that are not affected by the inflammation. So there's the growth of the non-inflamed areas, which is going to lead to a nodular shape with some areas enlarged and some areas normal size. Okay, I hope you understand that. The nodular shape is because only the areas that are not inflamed are growing. The areas that are inflamed are actually decreasing in size. They're becoming smaller. So this causes a nodular shape with some areas like, 1 second. Some areas are going to be large and then some areas are going to be small. Some are large, some are small. I hope you understand. So those are the 3 things that can cause hypothyroidism. There's millions, not millions, but there's hundreds of reasons that could cause hyper and hypothyroidism, but these are just some of the few common ones. These pathways are important for you to know, this one and this pathway over here, because I mean, you don't even need to know it. If you just like know the pathways, you're set, you're gonna know this. So we have things called goiterogenic. We have some things that have anti-thyroid activity or PTU-like activity. PTU meaning propylthiouracil, and these are called goiterogenic substances, right? Let me just get a laser. Goiterogenic substances, and examples of this are cabbage and turnips. So these, I mean, normally I did not know these costs. Like before I studied this lecture, when we were doing the report, I did not know this. This is shocking to me. But cabbage and turnip, basically, they have anti-thyroid activity. They block the thyroid's ability to utilize the iodine. And they basically, if you have an increased, if you basically consume them too much, it can cause goiter and hypothyroidism. Cabbages and turnips. So I don't know why this says hypothyroidism substances. It should say hypothyroidism symptoms. I'll fix all of this before I send you the lecture. But yeah, the symptoms of hypothyroidism are fatigue and somnolence. So basically, just whatever you see in here is the opposite of what you would see in hyperthyroidism, like polar opposite. So somnolence is increased sleepiness. You remember in hyperthyroidism we had insomnia. Here we have somnolence, which is increased sleepiness. You have muscular sluggishness. You have low heart rate, cardiac output, and blood pressure, which is the opposite of what would happen in hyperthyroidism. You have increased body weight, which is obesity. And the reason for this, if you remember, one of the B's was, you remember one of the B's? It was breakdown fats, right? Lipolysis was one of the B's, last B. Basically, in hypothyroidism, you're not going to have increased lipolysis. You're going to have reduced lipolysis, which means the fat is going to accumulate, and this causes obesity, right? And it also inhibits cholesterol metabolism, which means it could cause diseases that are related to this, such as like coronary artery disease and like increased blood pressure and all of that. Uh, Constipation, which is the opposite of diarrhea. Mental sluggishness, which is the opposite of anxiety. Anxiety is like overthinking. Sluggishness is thinking less. You're going to have depressed hair growth and scaly skin. This is why when you have someone with hair fall, one of the first tests that you do as a dermatologist is to check for the thyroid hormones because they're needed for hair growth and needed for smooth skin, right? So with someone that has a lack of thyroid, it's going to have depressed hair growth and scaly skin. You're going to have a husky voice and you're going to have myxedema. So basically just remember the opposite of hyperthyroidism. And myxedema is basically bagginess under the eye accompanied with the swelling of the face. So you look at this woman, you see the bagginess under the eye, you see the face swelling. She looks like she just woke up from sleep, and that's how they're gonna present. Like it looks like their face is super puffy, like they just woke up and like, but it's gonna be like that all the time. And the reason for this is hypothyroidism stimulates increased hyaluronic acid and chondroitin sulfates, which are glycosaminoglycans. I'm sure you did this lecture with Dr. Abdul Jabbar. It causes an increased hyaluronic acid and chondroitin sulfate synthesis, leading to bagginess, swelling, and non-pitting edema due to increased interstitial space. So this hypothyroidism, this hyaluronic acid and chondroitin is basically going to fill in the interstitial space, is going to expand, and this is going to cause the swelling and non-pitting edema. So how do you diagnose it? Basically, everything that we said about hyperthyroidism, you just reverse it. So there'll be low T3, T4, there may be high TSH, possibly, and you may have the antibodies against the iodine peroxidase in case of Hashimoto's disease. So the treatment is quite simple. It's just you take the thyroxine tablet, and that gives you enough thyroid hormones for you to go along with your day. So this is a very nice summary that I took from Dr. Yakin. There's two of them, but the other one is much more advanced and like focused towards people that are taking USMLE, and this one is much simpler and easier. So this is a quick overview that you guys can read. Instead of like the previous 30 slides, you can just read this and basically get almost everything. But yeah. And last thing I promise, look, this is the last thing. You have something called cretinism, which is severe severe hypothyroidism in infancy and childhood. It could be due to a genetic defect of the thyroid or due to iodine deficiency, right? And if it's iodine deficiency, then it's called endemic cretinism. Endemic because it's in like places that are underdeveloped, because that's when you have low iodine. So when the baby is born, for a few weeks after, the thyroid supplemented by mother is utilized by the baby. So it can survive off the thyroid given by the mother. But then after that, it needs to supply its own thyroid. So if they have cretinism, they'll have slow. Okay, these are the signs of cretinism, which is usually due to defective thyroid or iodine deficiency. You're gonna have slow, sluggish movement, right? Just think of the symptoms of hypothyroidism, right? Slow, sluggish movement, physical and mental retardation. Can you tell me why? It has to do with the two B's. Brain maturation was one of the B's. So if you don't have thyroid hormones, you're not gonna have brain maturation. So you're gonna be mentally retarded. The other B was bone growth and maturation, right? So if you don't have bone growth and maturation, you're going to have physical retardation. You're going to be short, right? So those two things are evident in cretinism. But if these people are treated with supplements, this all can be reversed and they can live a normal life. However, if you do not treat them, if you overlook it, then it can lead to permanent mental and physical retardation along with slow, sluggish movements. The physical appearance is going to be like this. They're going to be, I'm sorry for the picture, like I couldn't find a better picture, but they're going to be obese, right? They're going to be stocky, which means large, like broad, basically. They're going to have like broad shoulders and stuff. And they're going to have a large tongue and guttural breathing, which could lead to choking. So large tongue and guttural breathing. The large tongue could lead to choking, but they're also going to have a very characteristic breathing, which is called guttural breathing, which is um basically like you know how a dog breathes, kind of similar to that, like panting, basically. Guttural breathing. That's what guttural breathing is. So this is cretinism, and that's it for the lecture, guys. I'm sorry that it was delayed, and I'm sorry that it took so long, but it is a long lecture. Hopefully this was useful, and if you have any doubts, anything, please tell me, message me, or like you can ask at the university. But yeah, scan this code, please. It's gonna take like 10 seconds. It's just like two questions, and I would really appreciate if you did. And that's it. Thank you so much for attending. And yeah, thank you.